Okay, I think we should get started. I'm sure a few other people will trickle in because we had a full house signed up today, so we're very pleased about that. First of all, welcome to all of you here and those watching online. My name's Wendy Fenton, and I'm the coordinator of the Humanitarian Practice Network here at ODI. And I'm very pleased to be co-hosting this event today with the Secure Livelihoods Research Consortium here at ODI. And as you see from the title, we're calling this a humanitarian crisis and a development wake-up call, question mark. We're going to be exploring, the issues around the humanitarian crisis, but really focusing on the health system and the health sector. And there are two documents that inform the discussions today. One is research done by the Secure Livelihoods Consortium. This is a briefing paper, After Ebola, Towards a Smarter Model of Capacity Building. And then also the Humanitarian Exchange on the Ebola crisis. So you'll find copies of those on your seats. But as we all know, the West African Ebola crisis has claimed over 10,000 lives so far. And it's exposed deep fractures in the health systems of the three hardest hit countries, Sierra Leone, Liberia, and Guinea. And the national health systems have really struggled to cope under the weight of the crisis. And we also know that international aid agencies were not only slow to arrive, but they also took a long time to involve communities in the response. And we know that Ebola is now forcing the international community and affected governments to rethink how the health system can best be supported to withstand crises like these, as well as be strengthened in the long term. But some of the questions we're going to be discussing today are, how do vulnerable health systems actually become resilient ones? How can aid agencies better build trust with affected communities? And how, so that they can prevent transmissions during future outbreaks and stop these epidemics happening in the first place. So these are some of the questions that we want to explore today, that our panelists are going to be highlighting and that you're going to be discussing during our Q&A session at the end. Can I please ask you all, first of all, to put your phones on silent, but feel free to tweet. And I think we have the hashtag up on the screen, or we should do. If not, I have it here somewhere. Is it Ebola? Yes, that's right. Okay, let me introduce our panel of speakers now. We're very lucky to have with us today His Excellency, Mr. Edward M. Toure, who is the High Commissioner of Sierra Leone. He's the High Commissioner for UK and Northern Ireland. And prior to becoming a diplomat, he worked in politics. He served as a member of Parliament from 1986 to 2010. And during this period, His Excellency served as the Secretary General of the All People's Congress Party, and he was the minority leader of the Houses of Parliament from 1996 to 2002, having contested the presidency in 1996. In 2007, he was appointed leader of the majority party in Parliament and leader of government business under President Ernest Bai Koroma. So we're delighted that he's here with us today. He's, as you can understand, very busy and also stepping in very kindly because the minister was unable to make it, so he will have to leave immediately after he speaks. Before I hand over the floor to His Excellency, I'd like to introduce the rest of our panel. On my immediate right is my colleague Lisa Denny, who is a research associate in the Politics and Governance program at ODI. Lisa manages the Sierra Leone country program of the Secure Livelihoods Research Consortium, which of course we have to call SLRC because everything has to have an acronym, which examines capacity building in the nutrition sector. Lisa is the author of After Ebola, Why and How Capacity Support to Sierra Leone's Health Sector Needs to Change. She's the co-author, and Richard Mallet, her co-author, is sitting here in the front row. And this is a new report from SLRC and provides some of the background to what we're discussing today. On my immediate right is Marc Dubois.
I'm left.
Sorry, left. Thank you, Marc.
Politically.
Politically and geographically. Joined... Yes, thank you, Raymond. He first joined MSF in 1999. first working in the field, and then in Amsterdam headquarters, specializing in humanitarian affairs. Up until last year, Mark was the executive director of MSF UK, and his research on Ebola and the international aid system for ODI's Humanitarian Policy Group is due for publication in September, and he's going to tell us a bit about where we've got to with that in a few minutes. And then on my left, on the left of Mark, I should say, is Theodora Hamilton. Theodora is a representative of the Women's Response to Ebola in Sierra Leone, or WRESTLE, I guess, which is a consortium of women's groups and organizations in Sierra Leone working to complement the Sierra Leonean government's efforts to combat Ebola. Theodora is an executive member of the 50-50 group, which is a key organization within the consortium. And then we're very lucky, too, to have two discussants today. So on Lisa's right, immediate right, we have Ade Darame, who is the chair and spokesperson for the UK Sierra Leone Diaspora Ebola Task Force. That's a long one. Slogdat. He also co-edits the Journal of Sierra Leone Studies and is the editor of Promoter Africa magazine, which promotes Africa as a desirable investment and holiday destination. And then last but not least, on the very far right, is Mohamed Jallo, who is the CEO of Focus 1000. And Focus 1000 is an NGO in Sierra Leone that invests in the first 1,000 days of a child's life. He served in senior leadership positions with UNICEF in Sierra Leone, New York, Nigeria, and Bangladesh. And Mohamed spent 12 years also working with the Sierra Leonean government. Right, well, so that we don't take any more time, I'd like to hand over the floor to His Excellency, please.
Thank you very much indeed. I must let you know that I have to leave immediately after I've delivered my speech because I have another meeting with the Foreign Ministry. I know it's our line ministry, so I have to be there. However, I'll do what I can. Madam Chairman, distinguished ladies and gentlemen, it is my pleasure to address this distinguished gathering. May I personally give my immense appreciation to ODI for organizing this timely event. So here I am. I'm ready to go. As a country, Sierra Leone has faced many challenges, and each time we were determined as a nation that we would not be defined by these occurrences. Nearly a decade ago, it was a civil war, which ended in 2002. During that war, a lot of problems. Marauding drug thugs committed ghastly atrocities, amputations of legs and arms during the war. But we bounced back well with the help of our international partners. More recently, it has been the scourge of Ebola, which for many has been their introduction to Sierra Leone. We can never make light of these severe challenges. Nonetheless, we have shown time and again that we can rise, recover, and overcome challenges that always seem at their height to be insurmountable. Today, I will not bore you with long lists of statistics that you are unlikely to remember when this is over. However, I will mention some of the headline figures, and I hope this will give us food for thought. I'll also not engage in a blame game over who is or was to blame for not addressing the crisis soon enough. The arguments are still being fought in the international arena as to how to apportion blame between national governments and worldwide health organizations. Frankly, all these sides of that equation have to shoulder some of the blame, but that is perhaps for another forum, for another time. It's far better that we address some of the lessons learned and point towards some of the ways we can move forward. As Ebola reduces in threat, now is an opportune time to look back on what this has meant for our country and to look forward to how we as a nation hope to recover with the help of outside friends. As I look back at the devastation caused by Ebola and the path to recovery, it will serve us well to also look back at strides that were being made in various sectors before Ebola struck. The Ebola outbreak in parts of West Africa is the most severe in the history of the disease. The epidemic's unprecedented escalation is linked to the region's lack of experience with the virus, combined with a host of factors including culture, history, geography, weak health systems, over-centralized governance with inadequate accountability systems, fear, mistrust of state institutions, poor infrastructure, and a much delayed international response. The impact in terms of loss of human life and suffering is severe, as is the socio-economic impact. Sierra Leone is one of the worst affected West African countries by the Ebola virus disease. The disease was detected in Guinea in February 2014 and spread to Sierra Leone in May of the same year. Since then, over 3,000 Sierra Leoneans have been infected, and hundreds have died of the disease. While the epidemic has killed many people, mostly women and children, it is especially worrying that a proportion of doctors, nurses, and other health personnel are among the fatalities. This in itself has created a crisis within healthcare delivery in Sierra Leone. Our children have been orphaned by the disease, schools were closed, and over 2/3 of those infected are in the economically active age group. Furthermore, the epidemic has crowded our effective response to other diseases in the national healthcare system, and as a result, non-Ebola illnesses have added to the toll of deaths and suffering. Essentially, we were confronted with one of the greatest life and death challenges that global human community has ever witnessed. It was undoubtedly the most daunting crisis we have encountered since the end of a decade-long civil war, a crisis that has evolved to become multidimensional and complex. The president of Sierra Leone, Dr. Ernest Koroma, often reminded us that the Ebola scourge represents an extraordinary challenge, necessitating extraordinary measures. As a country, we took several short extraordinary measures, including initially declaring a state of emergency and shutting down the country for 3 days, which enabled over 27,000 educators to provide in-person vital life-saving information to every household in the country. This process was replicated numerous times in whole or also in part, reallocating millions of dollars dollars from other sectors to this public health crisis and life and death struggle, imposing stringent selected curfews such as no trading on weekends and or after 6 p.m., controlled celebration of major holidays, no public gathering, forced hand washing and temperature taking, closing down school system. And in order to contain the Ebola outbreak on a larger comprehensive government policy also called for increasing treatment centers, labs and equipment, providing more clinics, nurses, and other health workers in treatment and holding centers, providing training for national doctors, nurses, and other health workers in safe and effective clinical and nutritional interventions, providing logistical support to improve response time, including Ebola customized ambulances, logistics experts, and information managers. Thankfully, the world soon came to the realization that the Ebola virus disease ravaging West Africa cannot be tackled alone by the countries hit the hardest, that is Sierra Leone, Liberia, and Guinea, because viral diseases are not respecters of boundaries in a world that is indeed a global village. There is a sense that we are all in this together, solidarity that Sierra Leone and its neighbors applaud. Ebola should not have been a concern of only West Africa. It is a disease that impacts the world, a global concern that demands a global response. And as such, the response of the world to the Ebola epidemic must continue to be swift and effective to match the scale and urgency of the challenge until the virus is completely eradicated. I would be remiss if I do not salute the efforts of our international partners, in particular the United Kingdom, which has taken the leadership role in combating Ebola in Sierra Leone. Let me directly address the Ebola governance. I'm not breaking any protocols here to mention that the most striking aspect of Ebola crisis is that it revealed that our health sector, as our health sector stands, it was not in a fit state to deal with the outbreak, nor have those shortcomings been permanently addressed as yet. However, interestingly, before Ebola, the health sector ironically had shown the most dramatic indication of the president's vision against opposition from many quarters, principally the donors. He announced that there was to be free healthcare provision for lactating mothers and children under 5. To put this into perspective, this is a provision unprecedented in this part of Africa. The benefits are beginning to be felt as the nation gets used to the concept and reality of free healthcare. The difference this is likely to make cannot be overstated. The removal of health user fees in 2010 means that up to 460,000 women and 1 million children each year now benefit from free care. Progress since free health care was introduced has meant the number of women giving birth in hospitals and the number of children being treated for malaria have both tripled. The fatality rate for malaria in hospitals has been reduced dramatically by approximately 90%. The number of children dying in the capital's children's hospitals have halved. Free mosquito nets have been distributed countrywide to help prevent malaria, saving the lives of nearly 4,500 children. President Nkrumah has always made it clear that he subscribes to the mantra, a healthy nation is a wealthy nation. Even though the free healthcare initiative is in its early stages, by common consent, it is a game changer and one of the bravest projects ever undertaken by an African president. The disease has caused unprecedented social and humanitarian damage, accompanied by severe economic consequences. It has remarkably decreased the impressive gains made in economic growth over the years, as farmers, traders, investors, and a range of economic agents have extensively been affected by the epidemic. Key economic activities including agriculture, mining, manufacturing, construction, trade and commerce, transport and tourism have been disrupted, and this has hiked the rate of national unemployment. Prior to the epidemic shock, the economy of Sierra Leone had recovered remarkably following the end of the civil war of the 1990s and was on a trajectory to sustainable development. The country recorded a double-digit real GDP growth rates of 15.2 and 20.1% in 2012 and 2013 respectively. This was largely driven by iron ore mining, agriculture, construction, and expanded services sector. Macroeconomic stability had been considerably improved since single-digit inflation was recorded, as well as low interest and stable exchange rates and low risk of debt distress. The country's performance was encouraging not only on the growth front, but also in poverty reduction and human development. Notable progress has been made in peace consolidation and strengthening of democratic governance and human rights, and public capacity considerably built to deliver effective and efficient public services in a transparent and accountable manner. These efforts were manifest in the peaceful conclusion of the third post-conflict democratic elections of 2012. The epidemic has reversed all of these achievements and has left us with awesome challenges as we strive to end this catastrophe. It has caused untold havoc on the economic and social fabric of Sierra Leone, weakening the growth of prospects of the economy, and causing rapid reversal of gains made in managing our macroeconomic stability and improving human development. This has consequently held back government's efforts at fighting poverty. We are facing compounded post-Ebola challenges that demand planning now if we are to ensure timely implementation of actions, expedite socio-economic recovery and reduction of suffering of masses from the disease, and speedily chart a course to reclaim the path to sustainable development that Sierra Leone had laid out before the outbreak of the disease. Our recovery strategy is guided and encouraged by the conviction that while we have been negatively challenged by the Ebola epidemic, there are great opportunities we must not waste time to seize. The opportunity to reflect on what we could have done better to prevent the persistence of the disease in our country, and the opportunity to review our policies and systems now, not only in mainstream health sector, but holistically, so that we can emerge from the disease with the social and economic strength that will see us flourish more than ever. The immediate priority is to end the epidemic. It is also critical to address the adverse conditions that enable a localized epidemic to escalate into national crisis with serious regional and global ramifications, and to minimize the risk of its consequences. A strong and effective health system supported by regional and global disease surveillance networks are central to this endeavor. Experience from elsewhere suggests that even after the epidemic ends, the virus may remain latent in the region. As such, our post-disaster recovery programs must integrate systems and processes to ensure that the disease surveillance is improved, health systems are built back better, and in the conflict-sensitive matter, other relevant capacities must be in place with appropriate levels of funding to sustain them over the medium and long term in order to minimize the risk of collapse into the crisis. For this to happen, effective communication and information management and decentralized health delivery system will be critical. Related to this are effective incentives and payment systems for health workers, environmentally sound health care, waste management, creation of a health monitoring and effective and targeted social protection system, among others. In conclusion, I submit that we found out the hard way that Ebola is an unforgiving and a frightening disease. But we also found out that it can be defeated by working together in solidarity with our partners and friends, and most significantly, to scale up engagement. Every contribution counts. We cannot afford to allow the continued spread of Ebola in our region to outpace our response to the crisis, which has been done far too often in the past. I thank you very much.
Thank you, Your Excellency. Thank you very much for outlining the widespread impact, but also what the opportunities are for reviewing the systems and processes and making sure Sierra Leone is better prepared next time. I know you have to go, so thank you again for being with us this morning, and I hope the rest of your day is good.
I'm sorry, I would like to see some questions, but I'm called by my land ministry, the foreign office. I have an appointment there to see the head of diplomacy. Thank you very much for having me.
Thank you again. Right. Well, now that His Excellency has set the scene, I'm going to hand over to Lisa. And Lisa, I think you're going to talk about why and how support to the Sierra Leonean health sector needs to change. Go ahead.
Thanks. Great. Well, as was introduced, I've been working with colleagues on the SLRC Sierra Leone Country Programme for the last couple of years. This is focused in particular on how development partners can strengthen state capacity to prevent malnutrition. It involved a couple of stages of fieldwork. So we looked at the dominant approaches to capacity building in the nutrition sector at both the national and district level. In Cambia was our focus district. We also did some survey and qualitative research on the social causes of malnutrition and some of the barriers to preventing malnutrition. The Ebola epidemic then broke out, and we sort of decided to reframe the final stage of the fieldwork to dig a bit more into this issue of capacity building and look across the health sector more broadly to see whether the findings that we were coming across in the nutrition work applied more broadly in the sector. So it's the final synthesis report of this 2 years of research that I'll present today, and we've done the short briefing that you have available, and there's a longer report you can engage with as well if you like. So our argument essentially is that the Ebola crisis has not only revealed weaknesses in Sierra Leone's health system, but it's also pointed to deficiencies in the dominant approaches to capacity building that international partners have been relying on for the last 13 years. And in order to strengthen capacities in the future, we think that there are some ways in which capacity building needs to change, and this is a good opportunity to take stock and reflect on that. So, capacity building is one of the key features of international development. It's about providing development partners providing technical inputs to a weakly capacitated ministry or sector, enabling it to operate effectively and ultimately to solve problems without the support of the international community. That's the long-term goal. But it tends to be narrowly operationalized in practice, reduced to sort of the transfer of technical knowledge to particular individuals, for instance, through training frontline health workers, and equipping facilities with medical supplies. So it tends to look something like this. Essentially, this means that capacity building prioritizes resources, skills, and knowledge at the levels of individuals and organizations. And we heard this quote from one of the health workers, training, how much training does one person need? The problem is that resources, skills, and knowledge are the hard, tangible things that it's easy to measure, that it's convenient to put in a log frame, and in a results framework. But we know that capacity is about a lot more than that. It's also about how the context, the power, politics, incentives shape the wider system. So these aspects have tended to be overlooked. So for instance, you often have health workers who get trained in technical skills, and drugs and supplies are provided to health clinics, and these are obviously important investments. But if health workers are poorly paid, for instance, they're more likely to charge informal user fees to people at health clinics. They're more likely to sell medicines on the black market to supplement their incomes. That leads to drug stockouts in health clinics. That means that people lose faith in the health system, and that ultimately means that less people use the health system. So this highlights some of these political and incentive structures that are also critically important aspects in terms of the capacity of the health system and that have often been overlooked. So it's important to keep in mind, of course, that there have been some important improvements in the health situation in Sierra Leone since the end of the war that the High Commissioner mentioned, for instance, most notably the introduction of the Free Healthcare Initiative in 2010. So while I'm going to focus in my short presentation here on some of the gaps that we see, it's also important to recognise some of the important progress that's been made and not to discredit that. And in the report, we try and bring that out a little bit. In terms of the gaps, we refer to these as sort of blind spots, and we identify four. So first of all, systemic problems need systemic solutions. So capacity is theorised to exist at three levels that you saw in that previous slide, at the individual level, organisational level, and systems level. So individuals, people, and organisations, the structures that people work within, like a ministry or an NGO, they make up the system. And because the system level is more intangible, it tends to get overlooked. Organisations tend to prefer to train people and build and supply facilities at organisations, and these again fit better into the kinds of log frame ways of working that are so dominant in the aid community. And the assumption is that by building the capacity of people and organisations, what are essentially the building blocks of the system, that this will sort of aggregate up and you will get a more capacitated system at that higher level. But actually, there's quite a lot of research that suggests that's not actually the case, that the system also needs to be engaged as a whole. And dominant approaches miss the sort of connections between the different parts of the system that we know are really important, because actually so many public health problems are actually systemic in nature. So, when a health system, when a health clinic lacks medicines, it's the supply chains, the procurement systems, the staff incentive structures that we need to be thinking about. Or similarly, when a child is malnourished, it's the nature of the kind of gendered and cultural expectations and roles within a household and community that are part of that explanation. So those sorts of things lead to men receiving larger portions of food, more protein in their diets, men who are making decisions about how much money to spend on food within the household, where to take kids when they're sick. So these are also important aspects of capacity. Second, technical fixes conceal the human face of capacity. So capacity building has tended to focus on technical skills, which are obviously very important in the health sector, but they're insufficient on their own. They tend to overlook the kind of softer, intangible aspects. This might refer, for instance, to the way that health workers deal with patients at the clinic level, whether they treat them with respect or disdain. And this matters because it helps to determine whether people actually go to the clinic. So in a lot of our research, we found, quite unsurprisingly, that where people were treated badly by healthcare staff, where people were mean to them essentially or looked down on them, or even where they heard about other people in their community who experienced that kind of behaviour, they were less likely to use the health system. At the same time, healthcare staff aren't really disposed to be polite and look after people when they're also treated poorly by the state, when they have poor pay, they're in poor working conditions, poor living conditions if you're living in rural areas. And so it's not surprising then that their treatment of patients is also poor. So models of capacity building that tend to see problems as technical matters of engineering miss some of these softer social relational dimensions of capacity that are very important. Third, the complexity of seemingly simple programming. So a lot of capacity building is about behaviour change. That's ultimately what we're trying to see. But behaviour change tends to be more complicated than a lot of theories of change suggest, and multiple assumptions are made that we don't think always hold in practice. So a good example of this was some of the knowledge, attitude and practice surveys that Focus 1000 was involved in conducting during the Ebola crisis. And these actually found that people had quite good technical knowledge of what they were meant to do if there was a suspected Ebola case, for instance, but that they didn't do it in practice. This sort of mirrored something we found in the nutrition research in relation to mother-to-mother support groups. These are groups that NGOs set up within communities, train a lead mother, who then passes on infant and young child feeding practice knowledge to other mothers within the community. But again, so these are sort of widely relied on, but there are multiple assumptions being made about their ways of working, the messages they promote, the uptake of messages, the translation of messages into practice that we don't think really hold. And what this points out is that, what people know doesn't always determine what people do. Behaviour is subject to other forces, culture, gendered power relations, people's experience with the state, whether or not they have to pay for a service, how far away they are from a service, all these things. And they're also important to bear in mind. And then finally, plural health systems. So the state in Sierra Leone, as in most places, is just one provider of health services and is not always the most utilised. So you also have traditional healers, traditional birth attendants, drug peddlers, community health workers, and so on. And people engage with these providers differently across different systems. And we found that they're not mutually exclusive. People often use them at the same time, move between them. They're sort of a cooperative system, not always competitive. Capacity building tends to focus overwhelmingly on the state aspects of the healthcare system. Yet we know that traditional healers, for instance, play an important role, for instance, in kind of knowledge promotion around the Ebola crisis. So what does this mean for how we think about capacity? How can we use the Ebola crisis as a moment for critical reflection and learning on what we need to do differently? And again, we point to four implications, and in the report we go into these in much more detail and give recommendations for government, donors and NGOs if you're interested. But broadly, the messages are: future capacity building needs to be smarter. A business-as-usual approach is not going to cut it. So we were surprised when we were in Sierra Leone in March this year and talking to NGOs about what they were doing and what they were thinking of doing in their post-Ebola planning. Everybody said more resources were needed, but essentially people talked about using those resources to redouble efforts, to do more of the same things that they're doing currently. Now again, that's not to say that there haven't been some very good things going on. It's certainly not the case that we should be getting rid of all old approaches and starting again. But I do think that misses a moment to critically reflect on what we've been doing and think about whether there are things that we've been missing, the blind spots that we talked about. And in particular, I think we need to to engage with the complexity of how the health system actually functions and develop more nuanced theories of change that are actually going to engage with and reflect that reality. Second, capacity building needs to pay more attention to the intangible dimensions of capacity, including state-society relations. So the Ebola outbreak has underscored the sort of weak trust that exists between the state and society in Sierra Leone, and post-Ebola support needs to take this into account. So this will require improving citizen perceptions of the state and of the health system, including by improving community interactions with their health systems, with their local health clinics, which is something that's been shown in other contexts to help build trust between states and communities. But it will also require engaging with the power, politics, and incentives aspects of capacity, which fundamentally impact on health outcomes, as the example of health worker pay, for instance, demonstrates. Third, capacity building needs to engage with the ways in which people actually use the system, not how we think people should use the system. So capacity building needs to develop, a more nuanced understanding of how people move through the multiple providers available to them, and that will differ from community to community, and to sort of broker conversations about how this plural set of providers can work together to deliver quality health outcomes. And this has already happened to some extent with traditional birth attendants, for instance, but that kind of work, I think, needs to be extended. And finally, capacity building needs to target both the units of the health system as well as the connections between them. So more attention needs to be paid to the connections, the feedback loops, the relationships between individuals and organizations that make up the system. And this means, for instance, looking more at the linkages between the local, district, and national levels on things like data reporting and management, staff supervision, grievance mechanisms, and so on. So that's a very rapid-fire cover of quite a long report in 10 minutes. But the overall message is one about taking this as an opportunity to really critically reflect, try and move ourselves beyond some of our comfort zones, and see whether we can come up with better ways of doing capacity support.
Thank you very much, Lisa. I'm going to swiftly move along so that we can hear from Mark next, and so that we have the maximum amount of time at the end to hear from members of our audience. And I'd also like to welcome Dr. David Nabarro, who came in. We're pleased to see you. Mark, you're going to talk to us now about what does the Ebola sector response tell us about the aid system, based on some research that you've been doing with the Humanitarian Policy Group.
Thank you, Wendy, and thank you, Lisa, for really actually, in some ways, placing a foundation on exactly the kind of research that we've been trying to do. And that is, in some ways, to ask the next question, which is, okay, I think your analysis is spot on. Why is that so? And we've been trying to ask that. We think that the Ebola crisis, to a certain extent, has been a real magnifier of some of the gaps and problems in the aid system. It really shines a spotlight on some of those gaps in ways, and probably some of the strong suits and positives, in ways that other crises don't necessarily shine a light. And in some ways, our project, which is still a work in progress, it's quite large. And what I want to try and talk today about is really to focus it down. Instead of talking about the whole aid system, to look at, well, what do we think it tells us about the pre-Ebola, the development system, the development programs that were there and were put in place in order to build a health system. And as His Excellency pointed out, and as is obvious from what happened, the health systems in the three countries were not able to respond to Ebola, and were not able to really even get very close to doing that. So what does it tell us, and what does the aid system response tell us? The team, just to mention, we've got Caitlin Wake and Scarlett Sturbridge. They're also there in the corner, and Christina Bennett, who's not here. So I'm not all alone. And the project is, we hope, for a launch right here in September, just to put in a little plug. Also, we focused on all three countries. We want to try and keep it to Sierra Leone in the discussion, but we're talking at a slightly higher level. And there are very, very significant differences between the countries. Liberia had a system that was much more like the Sierra Leonean system, simply because of the enormous amount of Western aid that went in, and because of some of the structures that were being built, and also in terms of coming out of a civil war with very, very little in place and really having to build on that, and also showing quite some success in the 10 years. For instance, even though the system collapsed very quickly, what you do find if you look in places are quite some silos of excellence. The drop in maternal mortality, for instance, in Liberia from 2000 to 2010 went from 1,100 to 680, so a 40% drop. So you see that if you look across the sector of health, in particular in those two countries. Guinea is a slightly different context from that perspective. But what you see when you look at these countries is that while the system as a system didn't grow, you see quite some areas, and in particular those aligned to the Millennium Development Goals, those aligned to certain international programs. So you see, for instance, malaria, HIV/AIDS, maternal mortality, these kinds of areas where there was quite some improvement. And in some ways, that is part of how we are going about building capacity in what you might call silos of excellence that deliver on a set of targets and objectives, but do that in isolation in some ways. I think the report from Richard and Lisa really focuses very well on the fact that it does it in what you might call a modular approach, and that what we've created is sort of a modular approach to building systems. So I just want to run through a few of maybe the dynamics, and then I'm just going to try and bring it back to some of the things we're asking ourselves about why. So I already just spoke about, that if you were to characterize a lot of the work that was going on beforehand, and this is also true of humanitarian assistance, but in terms of building of the healthcare system or building the development phase, sexy projects, silos of excellence, verticality, targets that are set for concrete hard things like we built this many clinics, we train these many people. It's exactly what Richard and Lisa are talking about here. And these are targets that are, for instance, definable within electoral cycles. These are targets that respond to something. They're not just targets that we dream up for ourselves. These are targets that come from somewhere. They come from, in particular, from donors and from a need to be able to obtain money and to obtain funding for projects. And for those people who, whether it's private donors, who also, private donors like to see success. When was the last time you got any kind of a mailing from an NGO saying we're slogging on for the next 20 years trying to build this system, as opposed to we vaccinated 10,000 kids last week? Which one do you fund? And this is why it's asking why the system looks the way it does. Trust. When you start looking at some of the softer side of things, Ebola just put a laser beam on this whole thing of trust. What are those very first public messages that were used in the Ebola? It was, Ebola is real. The people calling for this big Ebola, our governors, our leaders, and this is particularly true in Liberia and Sierra Leone, it's a scam. This is some kind of scam to bring in money. And they didn't necessarily say that in Guinea. Why? Because in Guinea they were saying this is a scam to try and kill us by people who are ethnically and politically our enemies. So, the trust is already a major, there's a major issue here. If that's where you're starting, you're already in trouble. That's I think realization number one. And realization number two is how an aid community has done two things, I think, there is what we're seeing. One is ignored these fundamental softer things like the legitimacy of a government. How do you build, how does development occur in that kind of atmosphere of distrust? And that's at a global level, but it's also just right down there at the health ministry and the health clinic. If you don't trust that clinic and what they're going to do there, how do you, I guess it's basically a realization of the degree to which legitimacy and trust are fundamental builders, and yet the aid world isn't focused on that, and in some ways prefers to stay away from complicated, tricky, the corruption issues, things like that are very, very difficult for the aid world, and we always struggle with these things. But one of the ways in which we seem to have resolved that struggle is to ignore them and to pretend they're not there. Some of the governance issues. So, and why does that? Well, how do you get funding from people if you've listened to the British public on the topic of corruption and aid? I mean, this is a huge, huge matter for people. that think that they're donating money and somehow it's disappearing down rabbit holes. So trust says a lot about the aid thing. The communication. I think somewhere in Richard and Lisa's report, talks about, for instance, just you can't change behavior by providing information. And Ebola, if we did know that beforehand, you can read that in almost any evaluation. Read that in the Haiti crisis evaluations. Lesson learned, you can't change behavior by providing information. And what do we do when we got there? We provided information. And not only did we provide information, we provided the wrong information. We told Ebola kills. And we told them that it's incurable, rather than telling them, actually, you can survive, and there are things we can do to help you survive. And then we got mad at people as an international aid, or because people didn't want to go to treatment centers 6 hours away where they were never seen again. What a strange cultural belief that is. And we got mad at them because they weren't listening to us. And in fact, actually, they probably had been listening to us. We got mad at them because they had cultural practices like burials that actually transmitted the diseases. So what we did is we provided them with what we called safe burials. And this is just a small example. Safe burials, we all, I don't think I have to describe that to you. But what is it when you take a step back? And I think this is, this is highlighted in that sort of technical solutions for what are very, very complex sociocultural issues. And they don't work. And part of the problem, I think, is that is that we haven't asked ourselves why. Why do we keep doing this? Why do we keep making those same mistakes? What is it about us as individuals, as professionals, as professional medical people, for instance, not me, but us, that would lead us to keep to remain, for instance, on the safe ground of the biomedical advice? Because it's fairly defensible afterwards. You say, well, that's gold standard. That's what it says in the textbook, as opposed to actually advice that maybe isn't textbook, but would be more socially and culturally acceptable. So I think in the end, one of the things that we'd like to conclude, I keep pretending that we've already made these conclusions. They haven't been by the ODI editors yet. One of the things we'd like to conclude is that the real problem wasn't the culture of the Sierra Leoneans or the Liberians and their traditional beliefs. It was actually the culture of the aid system that caused a lot of these problems, and it remains invisible to the aid system. It's fine to have a culture that places a lot of emphasis on biomedical approaches, but we are asking people essentially to engage in a practice of unsafe burial. That's what we told them. What we would like you to do is make sure you don't pick up this disease from your beloved father who has just passed away from it. And instead, what we want you to do is put him in a body bag, incinerate him, and thereafter ensure that your family will be cursed by your ancestors for all eternity. Basically the worst advice you could ever give somebody who lives in a world which has a spirituality that is very different from the culture in which we arrived with our biomedical approaches. And all it means is that you need to interface between those things. It doesn't mean, as has been shown in the Ebola response, that with a little bit of finessing and a little bit of engagement, you can reach mutually agreeable solutions. It's just a question of doing that beforehand, not doing that with the resistance and realizing, because Ebola did a really nice job, when you get it wrong, it's not just that your aid didn't work, it's that the disease itself grew more strong. After an earthquake, if you do bad aid, okay, it doesn't make the earthquake worse, right? Ebola is really, really powerful that way. At the same time that the aid system had to deal with picking up the pieces, it had to deal with controlling the cause of the damage. And where it gets things wrong, it's not just a question of the pieces didn't get picked up. It's a question of we're doing more damage. We're driving the disease underground. It's passing faster because of the communication missed messages that we made. So I think that's maybe just kind of summing. How am I on the 10 minutes? I'm going to, when we start asking why, we start seeing culture of the aid system, as I just said, but also looking at us as professionals and the way in which risk transfer takes place. A lot of that communication, if you think about it, what it does is it basically says the reason why this isn't working is you guys. You didn't change your behavior. And it's a risk transfer. And you know, in an aid system that is fairly risk averse, but you know, to start, I guess what it is to understand why we make those those kinds of mistakes. You have to go back and start looking at what does that mean to work in a risk averse system, and how is this advice that comes up in evaluation after evaluation. We've all written this. I guarantee you, when I looked at the Haiti, the evaluation, the ISC evaluation of the Haiti response, you just have to do cut and paste or search and replace for the word Sierra Leone, Liberia, and Guinea, or Ebola, and sub in for Haiti in terms of engagement and communication with communities. And so I guess the points I would say, and I don't mean this as a criticism of Lisa and Richard's report, but it tees us up to say, well, why is it that way? Because in some ways, the lesson learned, the exercise that we go through after every one of these crises, and after crises that don't even make the newspaper, the lessons learned exercise is essentially a repetition of exactly what we just heard happens in when we look at development. We look at it in a modular approach. Look at our aid agencies. They're modular. They're modular. You got your health department, your logistics department, your human resources department. We work in a modular system. We think in a modular system. And it shouldn't be a surprise that our aid, in terms of capacity building, is modular. And we have to start asking, you know, or a second point, why is it then? And I think that's part of the answer of why is the system impervious to the research that says this capacity building isn't working. So I guess one of it is to look at ourselves, and the other is to start looking at the drivers. And that gets back to, you know, actually, is the aid system designed to do capacity building, or is it designed to receive funding to do capacity building? And there's plenty of critique out there about the extent to which the aid system is supply-side driven, not need-side driven. So we work hard, we have lessons learned that try and help us meet needs better. But in general, the structure of the system, its main architectures and drivers, is supply side. It's designed to obtain funding. And in that kind of a system, the health system in Sierra Leone, the health system in Liberia, that's what you get. So I will leave it right with that.
Thank you very much, Mark. Lots of provocative questions and issues there, which I'm sure many of you will want to respond to in the Q&A. I'm now going to turn over to Theodora. And Theodora, you're going to talk a bit about, you're going to reflect on the diaspora contribution to the Ebola response.
Actually, thank you. Good morning, everybody. I repeat again, I'm Theodora Hamilton. I am Sierra Leonean, British citizen, lived in the UK and Sierra Leone. The last 4 years, more of it has been spent in Sierra Leone because I'm an educationist, and I worked with young people, especially in those who've been in trouble with the law, in young offenders establishments. So I'm a literacy specialist, and I've had this issue of how information has been communicated in our environment, in the development environment in Sierra Leone. Just visiting, looking around, you see leaflets and stuff on how people should behave, how they should change so that development would happen. I mean, I just think, what was this language for? What is it for? But anyway, that is not what I'm here for. I had to say that because things that have been said, and this diaspora response, unfortunately, I cannot just speak about diaspora's response without Ressul's experience on the ground, yeah? And so I'll speak to you today from my experience as a woman living in Sierra Leone, as a mother, a wife, a daughter, and sister, and a social activist who was there when Ebola broke out last May. At the time, we were all like, what's that? What's Ebola? That was my question. So, come on, what are you going on about? Can we move on? Because the organization I am involved in with 50/50, the 50/50 group, our specialism is to work with women, empower women to be to take part in leadership roles, especially in politics, because the aim is to get 30% women in political decision-making positions. So, yeah, we're working on the constitutional review and also working on designing gender policies within the correctional institutions, like prison service. So it's like, can we just get on with our work? No, Ebola. Oh, okay, what's that? Oh, what? Okay then. Yeah, so you should use chlorine. You can drink chlorine. Phone calls. Yeah. Can you wake up? You wake up at 4 a.m. and make sure you drink salt, a lot of salt water before, and then you read 1 Kings chapter 2. What the hell is this? You receive text message, and every morning, the first thing in the morning, it was a Friday night to Saturday. This was early June. And then the neighbors come, did you get the phone call? Did you get the message? Because if you drink that portion, you'll be fine. You won't catch Ebola. And I thought, something is not going on right here. So after, we had a meeting to discuss our work. And then, we thought, we just shared our experiences. And we thought, we don't know what to do. I don't know if I should touch people. I don't know if I should even look people in the eyes. So we said, if we're feeling this way, then how are they, the most ordinary people who know nothing about this issue are feeling? So we decided that we need to do something. So the consortium of women in Sierra Leone came together, brainstormed, and then we thought, we need to see, because by then the news was coming in, nurses have died, masses of nurses have died in Kailaun, in Kenema, and the chaos. June was really a traumatic month for everybody. And I had chlorine, a bottle of chlorine in my bag. It's like, very good, you just have chlorine. And then I thought, okay. So we, can you go on to my first slide? No, my first. Oh, okay.
Is it this one?
Oh.
The right
Is it the
one.
green?
No, the right-hand one, apparently.
Okay.
Are you sure?
Okay, so by then people were dying, and we now know that over 6,000 people died, and it is the biggest Ebola outbreak the world has ever seen. So we engaged with the Ministry of Health, and we identified areas where we could help. Because, as the ambassador mentioned, there was the free healthcare service, and there was a helpline set up for that. But it was not going to be able to handle. And the same helpline was being advertised as the helpline for Ebola information. And then we went to the premises to find out, just went into the general hospital, government hospital, to see how we could help. That was the first area we thought, well, this is a problem. We need to get into this. So we tried, the Ministry of Health was very, very accommodating. We collaborated, put out press releases, and then we decided that, we put our money where our mouths are. We put money, everybody donated whatever they could afford. So it is a broad cross-section of women, market women, as the women of wrestled, where, oh, I need to go back. We have, I'll give you that one. We have representatives from the wide spectrum of society, the 50-50 group, MAROPNet, whose advocacy interest area is media. We have lawyers who are legal and advocacy specialists. The Women's Forum is the main umbrella. Lemonade, Sierra Leone Markets Trading and Sierra Leone Markets Women's Association. They are all the market women, I mean, most women are traders. They're petty traders. So they are represented as well within Resul. And we got their ideas, their issues as well. One problem, hygiene. 2 key areas that we identified were hygiene and communication. And the previous speakers mentioned communication and capacity building as well. Anyway, we when we came together, we realized that funding, logistics and distribution, education, personnel, strategies and policies were big stumbling blocks. We're going to be great stumbling blocks in responding to this crisis. So back then, since between July and August, through word of mouth, social media, we engaged with people, other Sierra Leoneans abroad or Sierra Leoneans in the diaspora, because there was widespread anxiety. Everybody was worried. It's like everybody in Sierra Leone was dying, because when you listen to the media, everybody was dying, and everybody who was in Sierra Leone thought, well, when will we die? It's like we were all in a time bomb. So we, after putting our monies together, I wouldn't forget the first lot we got was 4,200,000 leones. Translated into money that you understand, is about $1,000. That was a lot of money. We were so excited. Off we went. First hand-washing event at a central market in Freetown. That's a central distribution point in the eastern part of Freetown. And we took simple, basic stuff that people would take for granted. We put, water containers with gloves and soap. So by then, we were a bit more, we understood a bit more, because our ladies, we recruited young ladies from within our groups. We had representatives from the Army's Wife Association, Police Wives Association. So all these women came together, enthusiastic, giving their time, went for training the whole month, July, August. We were training with UNICEF to understand what to do, how to do it. So by then we understood that soap was good. So soap and water was supplied at 5 different points within this central market. And the diaspora, people in diaspora, were asking what they could do. Say, well, can you get us some chlorine, please? But anyway, it was not possible for individuals to send chlorine to Sierra Leone, So we slowly understood that chlorine was not necessarily what we needed. We just needed to get people to understand what to do and to make sure that the helpline worked and that people would actually go for help where they should go. And there again, if I can draw on the word trust. The trust and the capacity building, as the previous speakers have mentioned. And with that, because you see, the market women welcomed us on the ground. They were like, okay, so this Ebola, you mean when I wash my hands, I'll be okay, I'll be well. Again, education. We went out there, we went to more markets countrywide, and we were liaising with others who were in the diaspora, other organizations, because there are lots of Sierra Leone organizations or Sierra Leoneans everywhere, in every corner. I mean, during this time, it made me aware that we're everywhere, even though we are only about 6 million people, but we're everywhere. And people are really, really passionate about their Sierra Leone, so everybody wanted to do what they could. Even the alumni associations of schools were involved, or are involved, because it's still on. So moving on, we formed partnerships as Lemonade, Oxfam, International Rescue, IRC. I mean, we word of mouth, people around. We did some road shows in the USA, in France, Germany, everywhere, and also in the UK, because by then people had planned holidays and they were coming back. I had planned to be here in September, so yeah, by September I came in and just as things were unfolding, we just blended it in, liaising with others through phone calls, social media, set up a Facebook page, show people what we're doing, engage with the Commonwealth Secretariat and SLRC, Sierra Leone War Trust Fund, Save the Children, and we actually we led prayer sessions with Muslim and Muslim and Christian theme. Attended the CEDAW meeting. Anything we could do to, make our presence felt and get to understand what's going on. We also attended lectures at the London School of Tropical Medicine. London School of Hygiene and Tropical Medicine, and because we were like feeding back to Freetown, or what is happening out here, and there were by then more local, or even INGOs who were working out there, were collaborating with us to get information through our channel to the grassroots, because they were the most difficult ones. They couldn't understand what was going on. And after that, I'm doing all this. We lobbied with government officials and international partners, as Mark mentioned about the aid approach. The UN MIA was created, and we we did open letters to the UNSC and the SG, and the Women's Advisory Committee was set up to liaise with the UN mission. So that was really an achievement, although the advisory committee has not been really active, but we did engage with them. And we also insist that women should also contribute. Women who should contribute, even not with money and with their time, and to make sure we get Ebola out of the way. And we did research on Ebola on women. It was funded by IPAS and AWDF. And we continue to engage with academia here as well, academia abroad, wherever they are, so that, and those who are with global law firms as well, like Howard Lovells. Yeah, they are also very, very involved in supporting our campaign. And we just, we now are at a certain stage where we have, we know we've learned some lessons from this problem, from this catastrophe. It is really a catastrophe. We know that communication and early, in a timely fashion with stakeholders is necessary to prevent duplication of efforts, and understating how local culture and traditions can aid or impact projects. And as Mark mentioned, it is a case of, the cultural blame. Why blame culture? I mean, I personally, my brother passed away in April. My brother's been sick with cancer for over 10 years. Yeah. That's another story. Unfortunately, it's not a part of this. But I mean, when you have somebody, a loved one passing away, you know what it feels like, but you're not allowed to be involved. That is really, it was reality for me. I felt, how others would feel. Your loved one is taken away to a health center somewhere. You don't know the health center. You don't trust the system. And you don't see that person. Maybe you'll be given a number, indicating, that's the number. You might find the grave at some point. But again, these are all issues which we could be addressed. But again, I don't think it's just on the aid agencies. It's all on our local policymakers as well. So there is a lot to be done. More needs to be done. And maybe Ebola would help us address everything properly. And we continue to collaborate. We still look for partners, because through partnership, we would achieve more. You cannot do it on your own. I wish I had more time, but thank you.
Thank you very much. Thank you very much, Theodore. I'm sorry we don't have more time as well, but we will have questions and discussion with our audience and also our discussants in a minute. And I just wanted to say that what struck me was about your presentation was about how you really did address that, act as connectors. Referring back to Lisa and Rich's report, where you were looking really at how do you make and reinforce those connections? How do you develop and sustain those relationships and build the trust on the ground? So I think there are some very important lessons to be learned from that approach. Now, I'm going to move on to our discussants at the end. So Mohammed and Ade, you've listened to all of the presentations. I know that you've read the publications which are sort of underpinning the discussion here, both the Humanitarian Exchange and the report on the smarter model of capacity building. So do you have some reflections that you'd like to share with us, maybe starting with Mohammed on the end?
Yeah, well, good morning or good afternoon. My name is Mohamed Jallo, and I'm a public health and communication specialist. I am the CEO of Focus 1000, and I don't want to leave without finding out if you know about the first 1,000 days, because Focus 1000 is about the first 1,000 days in the life of a child. Let us just see how many people have heard about the first 1,000 days. Yeah, it's a very critical period. It's the starting from, the 9 months in pregnancy, and that is 270 days, plus 2 years, which is 730 days, and that gives you the 1,000 days. It's a very critical period in the life of a human being, and that is the foundation, and that's what we are doing. So I just digressed, to mention that, because I don't want to leave without making sure I talk about that. But let's go back now to the issues. Wonderful presentations. It shows, in fact, the power of research. It shows the power of reflection, that, we cannot continue to do things, and just continue to do more of the same. It wouldn't yield the desired impact. And we've seen definitely that, by reflection, you can sit back now and see, we've been doing well, but then where do we need to do things differently? I usually talk about skin, S-K-I-N, where S means you stop. Some of the things that you are doing, you need to stop them because they're not having the desired impact. Then you go to the K-I. Those are the things that you need to keep, but you need to improve on them. And then you move to the N. Those are the new things that you may want to bring in. So from the presentation, you can see that, the way aid is offered, the way we do things in the name of humanitarian, support, has these 3 components. There are certain things we need to stop. And I can tell you, from my experience, it has been mentioned, the blame game, that we cannot continue to blame, that, you know, we're supposed to do this or we're supposed to not to do that. But rather focus on the lessons we have learned. But also not just look at the lessons learned, but then see how they can be implemented. Because the lessons are repeated. Every now and again we are learning lessons. In fact, maybe we should change the name from lessons learned to lessons implemented. Because I find out that we are learning the same lessons. And if you look at Ebola, you know, we need to understand the context before we begin to apportion blames. You know, it's easy for somebody to sit here and say, but why is it that they are just why can't they just stop, you know, burying the dead? Why can't they just stop, you know, shaking hands? That's what some people have said to me. Why are they continuing all these primitive behaviors? Huh? But let's just look at ourselves. Let us look at some of the behaviors that we cherish. Take a simple one, like, you know, hygiene education. Right from the time when we were babies, we are told that, you know, we need to wash our mouth with paste and brush, right? If somebody says now to you there is a mouth infection, so please, you know, you should not wash your mouth anymore in the morning. How easy is it going to be for you? That's exactly what has happened. These people, you know, in Africa, you would understand when people say they want to get a boy, a son, and, you know, women say they want to get a daughter, it is because they believe that at the point of death, they put so much emphasis on death, at times even more than the living. That's my father would say to me, when I die, I want you to be around to cover my shame, to give respect to my corpse. Huh? And that means that when your father dies or a close relative, you should be there to close the eyes. Death is a very painful occurrence. At times when people die, their eyes are open, their mouth is open. You know, they mess up themselves. So you don't want neighbors to come and see. You are supposed to be there as a close relative. You know, to close the eyes, close the mouth, clean the person before you invite other people to come in. That is a good practice. But now Ebola is fighting against all those good practices. And that is what, you know, even the Quran and the Bible says, that you should give respect to the dead. And you should be able to shake hands. You should hug. These are good practices. But Ebola is saying, no, these are the good practices that have to be changed. So it's not going to be easy. And that's why it has not been easy. You know, so before blaming communities, which we are usually eager to do, we really need to make some reflection. You know, we look at the way aid is provided, as has been mentioned. Most times, it is easier to focus on the tangible things, the hardware, the hospitals, the health facilities, the ambulances, the treatment centers, the training of the personnel, because you can count them, you can quantify. Most times, we don't give emphasis on the software aspects. Remember that no matter how much facilities are provided, just because you have the facilities does not mean that people are going to use them. So, definitely, that is why, you know, I like this study. It has come out with the points that we should be looking at capacity building not only of the service providers, but also of communities that are going to be using those services. Because if the communities don't use the services, then it's useless. Look at Ebola. That is one thing we have learned. Ebola started in the community, and it is going to end in the community. A lot of, resources were pumped into the building of facilities, treatment centers, ambulances, but even up to today, we still have Ebola in some of the communities. And it is only with the engagement of those communities, by making those strategies owned by the communities, by involving religious leaders, traditional healers, community women leaders, youth leaders, that we would be able to defeat Ebola. But if you look at the resources, what percentage went into the building of capacity of communities? Those are the questions we should be asking ourselves as we move along. Because there is no way, you know, the health system is going to be revamped or strengthened if the communities do not own those programs. They would always see them as strange programs. Look at the way we were able to engage, Focus 1000, we were engaged religious leaders. They looked at the Bible and the Quran, and they were able to come up with positive messages positive messages to convince people not to wash dead bodies, which was a practice they were doing. And lastly, let me just say, the power, the evidence, you need evidence. Most times in our communication, the emphasis is on the messages. What I have learned, and I'm doing now, is that you need to put equal emphasis on the messengers, those people who pass on the messages. Because if you get the wrong person to pass the correct message, it would not be understood. And that's what I've seen, and that's what I'm doing now. We are using the religious leaders to pass the message to their own communities so that those of us who are the technocrats can stay at the back. Thank you very much. God bless you all.
And Ade, what about you? What are your reflections?
Well, I found it a most welcome report because as somebody who's engaged in a health-related charity in Sierra Leone, the Sierra Leone Cancer Charity, I'm a founder member and a trustee of that. A lot of what came over in the report actually is reflected in our experience in trying to deliver something in Sierra Leone. And if I can just say briefly that before we came along, and it's nothing to sort of brag about, but there wasn't a nationwide cancer strategy. There were various papers which had been sitting on shelves at the Ministry of Health, but there was nothing that had been rolled out across the country, and there still isn't. However, we became involved with government, and we're trying to roll that out across the country. And why I say the report sort of resonates with our experience is that one of the things that we found is this whole thing about capacity building. Every NGO, both local and international, that goes into Sierra Leone talks about building capacity. It's probably in the first one or two paragraphs of their sort of vision and what they aim to achieve in Sierra Leone. But actually delivering it and making it happen on the ground has been such a challenge for various reasons. And our experience in the health sector, for example, I guess come down to four things about recruiting the right people to deliver what it is you want to deliver, training them, retaining them, and then maintaining the systems that you've put in place. And so what we found is that a lot of people, you recruit them, they get trained, and then somebody comes along and off they go because they've got something better, a better job. In Sierra Leone, for example, because of Ebola, lots of healthcare workers, nurses particularly, who have in the past trained, have left Sierra Leone. You come to the UK, there's about, 3,000 to 4,000 Sierra Leonean nurses in the NHS, which is obscene, really. When we could very well need them and use them in Sierra Leone. For doctors, we have one person who performs autopsies in the whole country, or one person, and that's Dr. Owis Koroma. And not only does he perform all of the autopsies in Sierra Leone, when I was there last, he got a call from Liberia. Ellen Johnson Sirleaf had wanted him to come and do an autopsy. A member of parliament had died, and he was ill. He had a temperature that should have required him to be in bed, but he jumped on a plane and off he went to Liberia. So it's about recruiting, training people, retaining them, maintaining them. And all of these, you have to build certain packages. Sierra Leone is famous for the numbers of reports from friends of Sierra Leone and even from Sierra Leoneans that have come out and that have recommended things. But I tell you what, unless you get buy-in from government, from people on the ground, and I say government first because they can scupper everything and anything that you bring if they don't think it's their agenda, or if sometimes they don't think they're going to gain from it. And so you need that buy-in from the government. And of course, you need the buy-in from the folks who are going to deliver things locally. I talk about maintaining. We have lots of systems across the country, and I've mentioned this many, many times. Those of you who were last week at the ARI would have heard me mention that I went to a hospital in Bo, because I went to school in Freetown and in Bo in the 60s. And I went to a hospital in Bo where my aunt, my mum's sister, used to be the matron. And it was so dreadful an experience. I wept, and I'm not just saying this as a kind of, dramatic thing. When I was younger, when I was about 14, 15, and I used to go there, that hospital was so clean that I was scared to walk on the floor. Now, it was so filthy and bedraggled, I wouldn't send my worst enemy's dog there. I was shocked. And this is meant to be the main government hospital in Bo. And so it's about maintenance. So we can build and we can talk about capacity. But unless we retain it in country by giving people better packages and pay, etc., and maintain with sustainable systems, one of the things we're trying to do now is encourage nurses and doctors here to go and do part of their elective in Sierra Leone. We're trying to encourage engineers and architects to actually go there and work in Sierra Leone, because everything Ebola has shown needs to be rebuilt and restructured. And before I get given a 1-minute warning, I'll stop there. And happy to take any questions. Thank you.
Ade, thank you. Thank you, Ade and Mohammed, for those really interesting insights. Now I'm going to open up the floor to our audience, both in the room and online, for questions and comments. I'll take 3 or 4 in a batch and then refer back to our panelists. So I'm going to start over in the far corner of the room with these 2 people here and then move over here.